welcome to everyone. Thank you for coming today in this lovely weather. I'm Donna Kinzer, the Executive Director of the Health Services Cost Review Commission. We have some folks joining us on the phone too, so I just want to say as we get started with the meeting, speak loudly, speak towards the microphone so that we can capture your voice for those who are on the webinar as well as the recording that we're making of the meeting. As we get started, I wanted to make a special thanks to Alice Burton, who's been helping us with the organization of all of our stakeholder meetings, and as well as Shuli Chalakola, Steve Port, and Greg Reeves, who has been working with developing our website and keeping our website up to date, and all of the staff from the Health Services Cost Review Commission, who are working very hard to help with the implementation process. And also a special thanks to MHA, who I know is working very hard with many groups of stakeholders trying to prepare for this meeting, and all of you who have presented white papers in anticipation of this process. As we begin the process of this work group, and as we're moving down the road in implementing a new system, one of the things that I think that we need to keep in mind is that the goal that we're seeking is patient-focused care. With the better care and better health and lower cost is the end of what we're seeking. So we can easily deviate off of that path and short-term issues, but we do have to raise up and keep a little bit of a longer view as we move through some of the road and the potholes that will certainly creep up along the way. Just some of the rules of the road as we're moving down the road and we're charting this course together. We're going to have some critical short-term recommendations, and those of you who are not deeply involved in rate setting might find some of them a little boring before we get to some of our more strategic conversations about where we're headed. But we have some very critical short-term recommendations to get to relative to our update factor this year of how we update our annual rates. And so that's part of what we're going to be addressing, and we'll get into the work plan in a minute. And then we'll also be talking about principles and recommendations. And this is a non-voting work group, so we're focused on gaining consensus, and where we don't gain consensus of charting that and reporting that, and ultimately the commission will consider our recommendations and approve recommendations. So in many of our past endeavors, we've had a fairly, I would say, a narrow group of stakeholders. We have a much broader group of stakeholders. We welcome everyone to the process and to the table. Just because there are a number of new faces, it may be worthy just to at least quickly state your name, and let's go around the table and state your name quickly and your affiliation, just so we can start to get to know each other, since we're going to spend a lot of quality time together over the next 6 months. So, Michelle, I'll start with you.
I'm Michelle Mann. I'm the CFO at Frederick Memorial, or actually Frederick Regional Health System.
Me, Ray Gray, Chief Financial Officer, Meredith Medical Center.
Vinny DeMarco, I'm the President of the Maryland Healthcare for All Coalition.
Mike Robbins, Senior Vice President with the Maryland Hospital Association.
Kristen Bulio, Associate Vice President of Reimbursement for Adventist Healthcare.
Kevin Kelbley, CFO, Carroll Hospital Center.
Mary Jo Braceforth, President, Braceforth Health Research.
Albert Blumberg. I'm a practicing radiation oncologist at GBMC here in Baltimore, and according to this ticket, I am here representing the American College of Radiology. I currently have the honor of being national president.
Jim McGee. I am the Executive Director of the Transit Employees Health and Welfare Fund, and for those of you who are probably clueless as to what that might be, we are the entity that manages the health care benefits for the bus and subway operators of the DC Metro system. So we spend about $140 million on health care.
David Grant, Paul Parker, Maryland Healthcare.
Henry Simmons, Regional Vice President for United Healthcare.
John Hamper, Care First.
Dolly Mitra with the Hilltop Institute. I'm really representing the HMH's rate setting team for Medicaid.
Steve Ports, HSCRC.
Everybody knows about it. Shule Chillicothe Health Services Costa Rica Commission.
Dennis Phelps, Health Services Costa Rica Commission.
I'm Stu Gutterman with the Commonwealth Fund. And I'm Hank Franey with the University of Maryland Medical System.
And I think there's a few. Greg, can you tell us who's on the?
Yeah, we'll see Steve Kravitz. Steve Kravitz, if you can hear us, you may need to call in on the telephone. You are only showing up with a microphone there. Do you have a microphone at your computer?
I'm not sure. You can't hear me, can you?
Okay, yes we can. You do have a microphone.
Wow, how do you like that?
Know that. Good job. Ann Meck. Ann Meck, can you hear us?
Ann Meck is here.
There you go.
Okay, so thank you all again. And briefly, before we get into our agenda or into our meeting, I just wanted to briefly review. Whoops.
Okay, I'll mute them. Just tell Ann and Steve, because we're getting feedback from their speakers, if they could raise their hand if they want to speak, and then we will mute them. Otherwise, we'll get that feedback.
Okay, so Ann and Steve, we're getting feedback from you, so we're going to put you on mute again. If you have a question or want to make a comment, raise your hand on the website, and we'll turn your mic back on.
Okay.
Or you can call in on the telephone. Go to the audio tab and call in and enter your PIN, and then you can be unmuted the entire time.
Okay.
We'll look for your hand up.
Okay.
So in terms of the agenda, which we have up here, and I think you probably have in your handout, we're going to start with reviewing the work group charge and the draft work group plan. Then we're going to go through some review materials, if you will, looking at the new model and the global budget methodology, and hopefully we'll spend some quality time at the end talking about what it is we're planning to address in this process for the update factor, meaning the thing that will appear to be fairly boring to folks who aren't routinely interested in rate setting, and then also some of the factors that will be considering for short-term adjustments to global budget models as we move forward, and then ultimately some of the topics that we'll look at for a longer term, and hopefully get your input to make sure that we're thinking about the things that we need to do for the update process this year, and that we've got a full agenda there. So I'll turn to Steve next to take us through the work plan and the charge.
Great, thank you, Donna. As you may have heard at the kickoff meeting, I just wanted to
quickly review what the responsibilities are over the course of the next few months when we'll be meeting. As Donna said, we're going to be looking at, historically the normal update factor process that we've gone through. Look at the various factors that are involved with that and see whether it needs to be scrapped, whether we need to use that as a base to make some changes. Do we need to consider different things like how we address different types of volume, for example? People have said good, bad volume, or appropriate or inappropriate volume, or avoidable volumes, whatever you want to call it. And then how to adjust also, one of the things we'll be looking at is how to adjust for demographic trends as part of the payment structures that this group will be looking into and coming up with some principles and ideas around. Also, we struggle all the time with some of the major cost drivers and how to address those issues, things like some of the capital, technology, new services, and also look at things and how to address efficiency as part of the payment model and as part of the update process. We're going to need to kind of relook at the uncompensated care provision. Things have changed since the current methodology has been put in place. So we want to kind of reevaluate that, particularly given the changes with the exchange and the expansion of the Medicaid program. Perhaps we might want to look at undocumented immigrants as one of the factors to look at, since they may be a larger proportion today of the uncompensated care than they were years ago. The other is we need to make sure we have guardrails so that, as part of the update, as part of the payment model, make sure that we're managing the system to the requirements of the all-payer model. So we need to discuss how we do that and how we adjust, whether immediately adjust or do we adjust at the end of the year. So what's the best way to keep both on a statewide basis as well as on a hospital-by-hospital basis? How do we keep things in line? And then, of course, one of the more complicated issues that we'll need to discuss is how to deal under particularly global budgets and population-based methodologies, how we deal with market share, and how we determine what market share is, how we adjust for market share going forward. And then I know right now we're all talking about PPR, GBR, global budget today, but how do we progress from there? There's been a lot of talk over the years, studies done about potentially looking at population-based type models. So later on in the process, we have some immediate things we need to do right away. But later on in the process, we're going to start talking about how do we mature from the point where we, partially are today and going to be very soon in terms of the global budget strategy. So that's sort of the mission, the idea that during the course of the next few months that we're trying to achieve. Alice and staff put together, and I sent this out to you, and it's up here on the screen, how we plan to parse out these issues. As Donna mentioned, as I mentioned, there are some things we need to deal with right away. There's July 1st coming up pretty quickly that we need to address some issues for July 1st update factors and payment models. So for today, as you know, we're going to be providing background information on the global budgets. There are folks in this room who are intimately familiar with terms and some of the payment models, but then there are other folks who are new to this. So we need to work together and try to bring everybody up to speed. So we're going to do a little background at the beginning, and then get into some more details so that we can move forward from there and try to. We have some fairly quick turnaround on deliverables, as is shown in this document. So we'll look at some of the factors that were in the update factors in the past, some of the factors we need to look at today going forward, and then some of the short-term adjustments. That's what we plan to do today. Going forward, for the next meeting on March 13th, and I should say, well, no, it's the 20th we had an issue on. March 13th, it's from 1 to 4. We'll be in this room. And at that meeting, we're going to hear a report, the Performance Measurement Work Group. We have to
sequence these work groups in a way that they appropriately inform each other. One of the items that is obviously going to be on for July 1st is the quality programs. And traditionally in the past, we've had the payment work group that we had in the past kind of address the issues of magnitude. How much of the, whether it's an update or however you decide to do it, how much of that is based on the performance measurement. And it's been the performance group that has actually created the measures and looked at the national measures and tried to make Maryland-specific measures to compare performance on various areas of quality from hospital to hospital. So they've been doing a lot of work. They had a very long meeting yesterday, and they will be reporting to you as to where they are at this current stage so that you can begin to think about how that fits in terms of an update or your deliberations regarding how we should move forward with payment models.
Just to add to that, in addition to the magnitudes, I think we are expecting a broader discussion given that our model has been changed in terms of the way that we reward, whether we need to keep the revenue neutral models or whether we need to incentivize more improvements and create positive incentives in the system. So there's going to be, I'm looking forward to a big discussion on those issues.
So at the next meeting also, we expect, although we have not confirmed, we expect to hear some proposals, some ideas from some of the providers and some of the other maybe payers at a later date. They did put a white paper in, if you haven't had a chance to look at that, on the update factor. Care First, I should say, put in a paper that would be interesting to look at. I think we'll hear from potentially representatives from hospitals on some of the concepts that they may be thinking about in terms of updates, particularly for July 1st. And we think that'll be for the March 13th meeting, but we need to work together and confirm that. But for the 20th, and we'll continue our discussion today as well on some of the principles behind a balanced update next meeting. Then the 20th, we will go over the paper, the white paper that was provided by Care First, which attempted to address some of the update factor issues. We'll continue to discuss balanced update approaches and components. And we'll begin the discussion, as I mentioned earlier, about uncompensated care. So we'll hopefully have some data, and we'll start talking about concepts about what's the most appropriate way to move on the uncompensated care provision. So, and then April 3rd, we're going to try to, yes.
On March 20th, you might just want to point that time change.
Oh, yeah, that's the one. So there's been a little confusion about the time, and it had to do with Maryland Healthcare Commission has this room on that day. So we had to move the time around. It's now going to be from 9 to 11 in this room. So if your assistants have it in your calendar as 1 to 4 or noon to, or 10 to 2, noon, then it's actually not, none of those are correct. It's actually 9 to 11. And then by April, as I said, it's a pretty quick turnaround. We want to begin to finalize some recommendations on the components, the approaches, and the principles for the update factor and some of the adjustments that we should consider. Because we hope in April or May, to give public comment period and so forth, we want to take something to the commission, probably May, at the May period, so that we could have something, a final recommendation before July. I hope so that would mean June, is the intent. So as you can see, there's an April deliverable here. Beyond that April deliverable, and that may not be a final, fully thought through recommendation. It may just be, as it indicates here, what the components are and how we think about it. But there will continue to be time to develop even further as the public comment period goes on. But we want to get as far as we can toward an update factor recommendation for staff to provide an update factor recommendation. And then beyond April, we start talking more about the uncompensated care provision and look at some other, get some global budget experience from outside of Maryland. So we can, this was something that came up at the advisory council, is to look at other countries, other states, or whatever that are practicing this, and look at what some of the risks, some of the pitfalls, some of the advantages are that we can learn from as we move forward on global budgets and potentially population-based reimbursement structures. And I think that's as far as we want to go right now. It's enough to bite off for one day.
And again, I'd like to add, the draft is not a typo. We purposefully left it as a draft. We expect that based on our discussions, this agenda may change, and we feel the agenda is more of an organic document that will be updated as we go along.
So are there any questions about where we are and where we intend to go at this stage?
I think, Steve, the one thing you may want to kind of figure out, what's the drop dead date, and we know this July 1 is coming.
Right.
And probably put a big placeholder in it that we've got to work to, make, assume recommendation or whatever, but I kind of get that in there so it's late.
Okay. Yeah, there clearly is. Our goal is for May, to have a draft recommendation in May, yeah.
So we don't lose sight.
Yeah. Any other questions?
I have a question. You talked about this update factor being prepared somewhere in March or April. Is that going to be the final factor?
Don't believe so. The idea is our commission has a process that we normally go through where you present draft recommendations. They may not be fully finished, and with the idea of getting comments during the public commission meetings from the public, which is another opportunity for folks here and other folks outside of this group to provide public comment. So the idea would be, as far along as we are at that point, we hope to have a draft recommendation. It could be something on just these are the components that are going to be as part of our new system, if you will. These are the components that need to be considered. We make it as far as what we think the numbers behind each of those components may be, maybe some of them, maybe none of them at that point. We hope that we could have some numbers, some percentages and numbers behind each of one of those components.
So what's the latest day when it's going to be finalized? I'm asking you because for calendar year 2015 rate setting for Medicaid, we use those factors. So it would be very helpful if we can get in the first half of July.
Yeah. So we would hope to have a final recommendation for our June meeting. So that would be the second week of June. Sometimes that gets pushed to July, but that's not preferable because hospitals have, like Medicaid, hospitals have the budget as well. So that's the goal, is to have a final recommendation in June to the commission for vote.
And the second question, for this uncompensated care, the deadline is closed now for the white papers?
I believe so, right? Is that uncompensated care? The uncompensated care, when is that closed?
I think it's March 17th,
Oh, okay.
20th, in that range. I can follow up and let you know. The idea was to share a little bit of data that might help people think about those papers. We need to get with the timing of that. But probably be early March. Okay. Some summary statistics, and then paper. Okay. It's one later.
That's right.
Thanks.
Yeah, just a quick question. This is Mike Robbins. I'm trying to identify where in the discussions here, obviously I think before May or even April, we would have some discussion about these timing differences between the fact that we measure the waiver on a calendar year basis versus setting rates on a fiscal year basis, and how potentially, and I would hope it wouldn't happen, but potentially as we monitor things for the waiver, it might have us revisiting the update other than on this July 1st approval date. So I think that's something we have to accommodate. For example, this past year, as we all recall, we did an update just for 6 months, and then we came back in January and revisited that. So given the differences between calendar year measurement for the waiver, normal fiscal year rate setting, I think we should have built in here some time to discuss how that might be operationalized.
Okay. Is there a thought, Mike, that we may want to, do we move it to calendar year basis?
Our thinking after, and not that we're set in stone, but our thinking after looking at the timeline is that it's actually good not to have them exactly lined up, because as far as the all-payer data, we're very tight in terms of the timeline and how we can monitor that. But as far as the Medicare data that we also have to monitor, it's likely to the Medicare thought process is that we'll have good data by the end of the 4th month after the end of the year. We're not quite as optimistic, but at least it's not 18 months behind like it has been in the past, but it's probably 4 or 5 months behind, so it might be just in time to think about in connection with an update that would be on a fiscal year that we're on currently. So at present, we're still thinking that that's the smartest course of action, is to keep them on a separate path. Although I will tell you that after spending quite a few days working with global budgets, I do think that we'll end up wanting to come back and put a hard target in everybody's contract that we have for the calendar year end, so that we're not having any miscommunication with folks on where they're supposed to be at December 31, where they're supposed to be at June 30, and in some respects, December 31 compliance with their revenue targets almost becomes more important to us than June 30 compliance, because that's the hard stop for the calculation. So I suspect that that'll be something that we'll end up coming back and looking at.
So I think that raises Mike's question, about how we mesh this together, right? And so it's something maybe we make sure we make space for on here, Alice, I think. Right? Thank you.
Other comments and questions before we dive in?
Hey, Donna.
Yes.
Hi, this is Mike Curran. I've been on, unfortunately it was muted, but did want to say thanks for allowing me to participate this way.
Well, good to have you, Mike.
And we also had one more person who joined after the introduction.
And I'm sorry, I'm David Johnson from Citizen Consulting. I'm sorry because this is my first time to HSCRC, so I apologize. My navigator took me somewhere else on Patterson Avenue, a neighborhood, not here. So it is a pleasure to be here, and I hope to speak on behalf of the employer community who are our clients. We work with employers in Maryland and also really throughout the United States, but with a lot of employers here in Maryland to really help them manage the cost of their employee benefit plan. So hopefully I'll be able to bring to our conversation the employer perspective on what we're doing with the payment models. In about 3 months, your car will be on autopilot right here. Yes. All right. Always, if you have questions or comments throughout the process, feel free to use the email, what we have on the website, so we can. So even if there are recommendations or something as we discuss, or changes to language or things like that, feel free to, between meetings, email us. We'll keep up to date on that. So with that, Donna, you want to do the review of the model?
And we're going to go quickly through some of the background materials, but we do have a lot of folks who aren't necessarily steeped in what we're doing to the same extent that all of us are. So we wanted to make sure that we step through briefly some background materials about where we're headed. But also, I think it's a good idea for all of us to keep in mind where we're trying to head, so that we don't necessarily get stuck in the ruts of the here and now as we move forward. We're going to cover a couple of topics. I'm going to start kind of at high level with an overview of the new all-payer model. Then I'm going to really focus a little bit in on what does that mean from a revenue standpoint or a calculation standpoint from a statewide basis, and then ultimately zero in on, well, how does that get implemented at a hospital-specific basis, so that then we can begin to see how do we build this model and an update process for this model going forward. So that's where we're headed with the background. So the new model was that we're putting in place was based on an application to the Center for Medicare and Medicaid Innovation. It was approved effective January 1, so it's already in underway and in process. It focuses on a brand new approach to rate regulation that is really the most significant change in the last 40 years in Maryland. And it moves us from our current test, which is based on a cost per admission for Medicare inpatients, to an all-payer per capita test. So, so the focus is going to shift very much to population health and delivery system redesign with this new approach. And as we go through the shift is really to focus on patients and how to improve their experience, their health, and lower the total cost of care. And we're focused on in the implementation process of having hospitals gain control of their revenue budgets to assist them in navigating that process. One of the things that we've had an advisory council that has met to really give us some overall advice and implementation. And one of the things that our advisory council said is, as you go through this implementation process, make sure that you keep your eye on the things that we have to accomplish early on in this model, which is to bring the total hospital per capita revenue growth, to maintain it within a ceiling of 3.58% per capita for the first 3 years. And so that 3.58% is based on the long-term state economic growth rate, or the GSP, and also that we have to produce savings for Medicare over a 5-year period, and that's a $330 million savings figure. It doesn't sound too aggressive until you think about the fact that it has to be approximately 0.5% below the national average Medicare growth rate per year. So that puts a different perspective on it, and it's a dynamic number that we don't know in advance exactly what we have to produce. It's 0.5% below national. And then finally, the new test also focuses very much on patient-centered measures, unlike the old test, which was just financial. And we have two specific requirements, very specific requirements, to reduce Medicare readmissions to the national average over a 5-year period, and to reduce preventable conditions under the Maryland hospital-acquired condition program over a 5-year period by 30%. There are many other quality measures and quality targets that are part of the model, but those have 2 very specific requirements. We don't want to advance past that because we really want to focus on those. We really want to focus on those here we go. Now it's probably going to skip. So this really creates a whole new context for the Health Services Cost Review Commission, and is why that we have so many new parties at the table, because we're focused on aligning the payment with new ways of organizing and providing patient care. And we're focused also, as always, in containing the growth of hospital costs, but now total hospital costs on a per capita basis in line with the requirements, and continuing to evolve the value payments that were that we've already begun with the hospital-acquired condition program that Julie mentioned earlier, around patients, and then newly around population-based efficiency measures that will work together to create. The priority task of getting this underway and getting control over the revenue budget is for us to transition to population-based and global models, and we're well along the way on that path. As we begin to talk, and we have other work groups working on this, we have major data and infrastructure requirements that we need to execute on in a short period of time to be able to monitor and manage under this new model. And I'm not going to go through this list, but just there are many things going on in the state that we have to integrate with and think about as we implement our new payment models and as we look to align. Just in terms of thinking about where we're headed, because all of what we're doing is in the context of where we're headed, we have a 5-year model with this new all-payer model. So kind of in terms of the short term, we're focused on looking at conversion to global models for hospitals, and making those models work. And as we move down the road, we'll be focusing on more population-based concepts. That those may include payment models, but they are also refinements of things that we do with the global models to make efficiency measures, to make other measures more population-based and patient-centric as we move toward that process. Now, if that timeline wasn't aggressive enough, then at the end of the 3rd year, we have to file an application for a model that would be implemented in the 6th year that would include the total cost of care, not just the hospital cost of care. So this model is just hospital care, but the next model is focused on including the total cost of care. And so that's something that we have to keep in mind as we develop the parameters for how we want to evolve this model. And I'm not going to go through every detail on this slide, but maybe focus more on the current part of this slide so that you'll know generally what are the things that we're focusing on now, which is the short term, and that is transitioning to global models and changing volume policies to make sure that we stay inside of those limits and that we have folks focused on new delivery models. The revenue update process for the model, which is the model, which is exactly what we're talking about today, monitoring and compliance under the new models, which will be key to some of the success measurement and updates that might come out of this work group as well. In terms of making this new approach work, we believe that avoidable utilization, we must reduce avoidable utilization in order to make the model balance under the 3.58% target. So we're placing great emphasis on that because not only is it focused on care delivery improvement, but also on cost containment. Part of the charge of the new model is to align with physicians and other providers in terms of the delivery transformations that are taking place in those communities. So we need to bring those perspectives to bear during this process, and another work group is working on that, as well as looking at things like shared savings programs with physicians. Ray, you had a question?
Yeah, Donna. Steve early on mentioned that there's an interrelationship between the technical group and this group, and we hear, and I may have the name wrong, and you've got a number of groups, you've got a physician group. What's the relationship between the group that's looking at alignment with physicians in this group? Is there any?
I think that there certainly is, particularly as we get to looking at future models. I think that we would clearly need to be meeting with that group to see what they're thinking about and how it would drive the development of our models forward. And there may be some things that would actually affect the update process that would come out of the physician work group, but I don't know that yet.
But you haven't established a formal interactive process between this group and that group as of today?
Not as of today, but as we get through the agendas, we would see what the best point would be. I would definitely think as we got into the future models that there is a definite need to have the groups together.
Okay, thank you.
One of the things that I want to point out as we move forward is that we need to make sure that everybody is thinking about and messaging the new model in a way that is patient-focused. And one of the examples that I look back to is I was working in the state in the 80s when we implemented DRGs, and back then, nationally and in the state, we had about 37% more beds in the system than we have today, and today we have 36% more people. So the delta between beds and people is pretty wide. Our use went down dramatically of hospital beds, and we used that money to pay for new services in the system. We used it to do things like cardiac care and better orthopedic care, and to pay for drugs that actually reduce future utilization as well. So one of the things is that we're trying to free up money to use it for something else in the system. This time it might be population health, or it might be it might be something else. But clearly we're focused on creating a model that delivers savings so that we can reinvest them in the right services for patients. And so that is the end game that we're focused on. And there's clearly amazing things still going on the technology side that are really reducing inpatient utilization. One of the most exciting meetings as far as that goes that I've had during this global budget process is with the transplant doctor from university. It told me that the kidney transplants are now getting to a one-day stay. So, they're very close to a one-day stay. So things are still moving in a very rapid direction relative to that front. And there are exciting things going on that should reduce utilization and improve quality, like the Maryland Hospital Association announcement earlier to focus on reducing sepsis. And if we made a measurable mark on reducing sepsis, it would have a very significant impact on quality improvement and cost reduction. And so that's the messaging and the goal that we should all be looking at as we move forward with this model. And with that, I want to turn and start talking a little bit more about nuts and bolts, things that aren't very exciting, but that we really have to work through in order to meet that May deadline that Gary was talking about to get numbers out. And I want to just start kind of reviewing at a very high level how the old rate setting components worked in our system, and then move forward on how that moves, how we're thinking about that in the new system. So in our current old system, and it's not current anymore, as of January 1, it's gone. So it's the prior system. We had an annual update, which was typically inflation minus productivity minus policy adjustments. We had financial incentive programs that Shuley mentioned relative to quality, and other financial incentive programs. We have uncompensated care adjustments. We have other one-time adjustments, and which are referred to in the industry as slippage. I don't know where that ever came from. Some of those one-time adjustments are special adjustments. And all of those were applied to our rate base or our cost per case, but we didn't know how much the revenue was going to be or the cost to the employer was going to be at the beginning of the year, because we didn't know what the volume was going to be. So the key variable that was open is the volume. Well, that all changes with the new system. So basically, with the new system, the new model, we know in advance at the beginning of the year what is the maximum amount of revenue that can be charged in the system. And basically, to give you a high-level view of that, roughly our revenue is about $15 million. It's focused on residents of the state of Maryland. So if we take the out-of-state volume out of the revenue, we increase that by the 3.58% hard cap increase, and a population increase of about 0.6%. That gives us a revenue budget to manage of $14.4 billion. So that's about a $600 million increase in the revenue budget that is allowed as a maximum allowance under this new model. So in terms of the approach, what we're focused on with this new approach is we know what is out there to be as a maximum allowance, and so now our job and what we're going to be working on together is how to translate that now back to the components of an update factor. So what are the pieces that we need to account for in an update factor, and how are we going to account for inflation or trends? How much are we going to devote to financial incentive programs? And how much is going to be allowed in that system for volume? How much for population growth? How much for any other types of volume? And we still have other one-time adjustments to contend with. And how are we going to account for those? How are we going to account for capital adjustments? changes in uncompensated care. So kind of at an overall statewide level, that's what we're focused on. And as we move that into the context of hospitals and hospital-specific, what we're trying to do is to drive that model down to the hospitals, because if you have the statewide model and the hospital model working on the same types of systems, it's no surprise that it would be easier to manage the hospital model if it were operating with the same metrics. So again, under the old model, the hospitals had unit rates and cases, and those rates were increased under the system that we talked about. With the global model that we're implementing now, we're taking the revenue from the existing model and converting it over to a global model at a point in time, at this point in time, and then what happens to that revenue from that point forward are based on the policies that are developed in this work group and adopted by the Commission, policies for update, for how we're going to do population adjustments, and other adjustments. So a hospital, like we will know the revenue for the state at the beginning of the year, a hospital will know what its revenue budget will be for the year at the beginning of the year, absent any events that Mike Robbins was raising, where we might have some untimely adjustments, which we would not look forward to, but generally we would be focused on delivering a revenue budget at the beginning of the year. So that gives a lot more certainty to a hospital to be able to go out and make changes related to population-based approaches and trying to get the volume down without where we can improve care and lower costs, and doing that with a stable budget underneath. In terms of the models that are ultimately envisioned as population-based, we have the total patient revenue model that has been in place for 4 years now, and we are implementing a global budget model for hospitals coming on to a global budget now. And in the future, we would expect other derivative models of population-based revenue structure to develop. Also, that we would continue to develop and progress on measures of revenue and tie them to performance, so that we're looking at the patient-centered and population-centered performance measures as well as efficiency measures. As of effective January 1, the HSCRC approved for this year that hospitals could either elect a global model, or they could stay on the current model, but with some changes in the volume factor, so that we could be sure that the system would stay on course. So we may have 3 models in effect this year. We may have the TPR and the global budgets, but we also may still have some hospitals on the charge per case, or at least some revenues on a charge per episode or charge per case system. So we'll need to think about updates for those revenues and models as well. For those who have been involved deeply in global models, you're probably getting the drift of how they work, but for those who don't, we just want to fly through just kind of at a high level what is involved in the global models, and this is straight from the policy that the Commission adopted. we're starting with a base period of revenue, and for the global models that we're implementing now, we're using a base period of fiscal year 13. We're providing an update to those models, or an enhancement to those models for some infrastructure costs, and making population adjustments or other leveling factors for volume through the end of December, when the conversion point applies. Then once these budgets are established, then these budgets will be updated based on the inflation or balanced update factor that we work on and that the Commission ultimately adopts. And they'll also be updated for quality-based and value-based adjustments that we'll bring in at our next meeting, start to bring in from the performance work group. Additionally, there are other things that may result in adjustments to the global budgets, including shifts of service. So as you might imagine, as people think about different ways to deliver care, some services may be shifted to unregulated settings, and when that happens, we need to reduce the global budgets. Also, we're focused on how to make adjustments for market share shifts, which we'll be talking about later. And last but not least, we may have other things, and again, this comes back up on the agenda too, a certificate of need or capital types of issues that we need to think about. One of the things that that staff has done in the process is spend quite a bit of time working on a demographic adjustment, and we'll want to review that with you for your input and enhancements to that adjustment. And it's I think we'll probably save the details of it for another day, but it is a fairly sophisticated approach to the population adjustment based on virtual patient service areas that takes into account where all of the patients from each hospital come from. One of the things that struck me during the initial evaluation of data, and that will come up again as we start thinking about how what we're doing affects Medicare, and ultimately how we should do trending and updating. The all-payer line, which is the top line, we have a graphic of what's happened with the all-payer growth per capita on the top line, and the bottom line is the Medicare growth per beneficiary. And so one of the things that you can see is that the Medicare growth per beneficiary has been consistently lower than the all-payer line. And so that, yes, do you have a question about that?
Does all-payer include Medicare?
Yes. So actually, if you took Medicare out of all-payer, there would be an even greater gap. And so it's but it makes for some interesting policy thoughts as you start to think about what does that mean, and how should we think about that going forward in terms of how we think about where we need to arrive, and also how do we do update factors. I thought it would be good for Steve to talk about how we did update factors last year.
Yeah, there are many of you in this room that were in this room when we were trying to decide what to do here. But Donna talked earlier about the normal process for update factors and some of the normal factors. She talked about slippage, there's productivity and policy adjustment. Well, 2014 was an anomaly, and it was an anomaly for a lot of reasons. There was a lot of uncertainty going on. One, there was a very low update factor in the year before. It was 0.3. across the board. So there were some, you could see that impact on hospitals. So there were some financial issues for many hospitals in the state. Also, at the same time, sequester hit, which impact Medicare reimbursement to hospitals, which had a further financial impact on hospitals. We were also at the same time negotiating, had no idea when or if we would get a signature from CMMI. It could have happened during the course of 2014. So we wanted to, again, that was another piece of uncertainty, and we wanted to make sure that we could manage as soon as be flexible and manage to a new waiver as soon as we could. So the commission asked the staff to to come up with a recommendation for a fiscal 2014 update factor, taking into account market factor cost inflation, sequester impact, financial condition, waiver cushion, our current waiver cushion if we had to manage to our previous waiver cushion or we manage into a new waiver, and then any other factors. What the staff had asked the commission is to, because of not knowing when or if there would be a change, to do an update factor for a 6-month period, do a stub period for an update factor. So we adopted the 165, which I'll in a minute show you how that was calculated. We adopted the update factor for July 1st through December. The commission also asked the staff to come back in December and look at all of these factors again to see if anything's changed. And little had changed at that point, so the commission decided to maintain the 1.65. I should also say that in the first half of the year, there are a series of one-time adjustments and other adjustments that hospitals see from year to year based on rate compliance, based on your quality, quality adjustments, and many other adjustments on compensated care. They decided in the first 6 months not to apply those, but then to wait to see what happens for the second 6 months. They then were applied, or will be applied.
Are applied in the global
effective, budget. Yeah, are applied in the global budgets effective January 1st. So all of those adjustments actually were then made for as if they were made for the entire year. So the impact was as if those adjustments were made for the entire year. So as I said, you can go back one. So 2014 is not your normal update factor. A lot of times we have a lot of other lines in this where we look at slippage, we look at, there are volume adjustments and productivity and policy adjustments. What we did for 2014 to come up with the 1.65 is we took market basket. The commission for years has used Global Insights, the most recent book from Global Insights for hospital services, to determine what the reasonable market basket is. And there's always a little difference in once the actual numbers come in, so we sometimes have a factor built in for change in the market basket. And last year we just had a policy adjustment. Now that policy adjustment, if you look down below the chart there, basically was the market basket from Global Insights minus labor cost. What staff determined, which was about 1.38%. And the reason why labor cost was chosen is because there are a lot of factors that hospitals can't control that are built into the market basket. But there are some factors that hospitals can control, and one of those things is labor market. So staff thought that that factor's labor cost, the labor cost factor would in essence be like a productivity factor. And then recognizing the financial condition that was occurring at many hospitals as a result of things I mentioned before, sequester and also the low update factor in the prior year, there was a positive 0.72 adjustment as well, so that the total of those two policy adjustments was negative 0.66, which gave the base update of 165. In previous years, there usually is a case mix, an allowance, if you will, for case mix. It's been about 0.5% in recent years. the staff and the commission felt that for this year we were not going to have any allowance for case mix, that it's all built in, if you will, to the 165. So that's what happened in fiscal 2014, the current year that we're in. And then this is not saying that this is the model for fiscal 15, but at least it gives you those who have not been involved in this process, gives you an idea of how we arrived at the current update factor.
So before we move forward into talking about, what is staff thinking about the factors and what we need to put on our agenda and discuss over the next few months, are there any questions about these?
You used two terms on one slide. I'm a little familiar with the total patient revenue concept that's been used for the Eastern Shore hospitals, but how does that really differ from a global budget revenue target? What are the factors involved? Are there really significant differences or more just semantic?
The global budget model is based off of the total patient revenue model because being that we were going through a rapid implementation, we needed to base our changes on existing policies. So the commission has to adopt policies, and so we had a policy in place for total patient revenue model. So we have adapted that model. It does have some it has some differences, and we can actually create a chart if that would be helpful for people to show what the differences are between the models. But okay, so we'll do that before the next meeting. But I'll tell you some of the key differences. The global budget model is an evergreen contract, meaning that it continues to renew automatically, and it starts actually for the hospitals that are entering into it, starts July 1 of this past year, and it goes through June 30, and it renews unless canceled. So you all know have some of those contracts in your personal world. So that's how that contract works. And so the commission really establishes, once you get to July 1, the commission really establishes, and you're working on the work group that recommends to the commission all of the policies to update that model. In contrast, the TPR model agreements are for 3 years, and some of the adjustments in the TPR models were established up front. So, for example, the population adjustment for the next 3 years was actually specified in the TPR model, whereas it's going to be specified through commission policy with the new model. There is a total revenue limit on the undercharge or overcharge limit on the new model of 0.5%. We really can't tolerate a lot of difference from the approved revenue in our new global budget of 3.58. The current models in place focus on a 1% corridor. Well, 1% on 3.58 is too much. So we're really focusing on tightening that, and we'll ultimately probably go back to our TPR brethren and tighten up the corridors for them. But at this point, that is one key difference.
Do you anticipate that at some date in the not-too-distant future that there will be no difference between, other than the evergreen concept versus the 3-year contract, between the two models?
Well, those will be discussion points for the work groups. The TPR model update process was the same as the charge per case update process. So one of the things that we're going to be talking about is, well, if in the charge per case we took inflation minus for productivity, and one of the thought processes is that, well, you were getting in productivity through volume increases. So the more volume went up, your cost per unit dropped, and that is taken out of play in the global model. So one of the discussion points is, do we change do we differentiate the inflation update for global versus non-global, and then would we do TPR and the new GBR model, would we do them exactly the same, or would there be some differentiation? So I'm not saying there should be a differentiation, but it's a discussion topic.
Thank you.
Yes. A quick question about the Medicare savings. That we have this big target on a moving, trend downward for Medicare, and does that includes obviously inpatient? I'm assuming it also includes outpatient, and is it correct that it does not include other services for Medicare beneficiaries in terms per capita?
That's
ASD and lab and those kind of things.
That's correct. The savings include inpatient and outpatient hospital only. So not now it does include people, residents of the state of Maryland. It's all of their services for residents of the state of Maryland. So it does include their trip to Florida, the hospital that they go to in Florida. So it's kind of like the ACO concept. Once you take responsibility for the resident, anywhere they happen to get service, it's in the calculation of the savings target. So and there are some guardrails that do look at total cost of care, because Medicare is wanting to make sure that we're keeping the eye on the total cost of care, and that we're not shifting, we're not making the hospital model work by shifting to unregulated services, the things that we don't regulate. So it does come into play, but it's not part of the $330 million.
Just real quick, that what you just said about Medicare, does that apply to non-Medicare also? That if you go to a hospital in Pennsylvania and you're not in Medicare, that's counted as part of the global budget?
No, the 3.58 is for Maryland residents in Maryland hospitals, because that's what we have the capability to measure. There is no all-payer data that is. There is no gold standard for all-payer data that we can actually get that information from.
Okay. I have a question. In the past, when we got the numbers or factors from HSCRC, some were based on like the inpatient outpatient split. Are we going to lose that capability with the new model?
So the question is, the Medicaid program got inpatient and outpatient split. Will we lose the capability with the new model?
Is that when we had the separate update factors for inpatient and outpatient? Is that what you're referring to? Yeah, we just had it for 1 year, last year.
Because we have been following the same model for like 15 years now, and that's how it is built up. If we lose that capability, we need to know early. That way we can revise the model, because we come up with the rate in July.
The rates are the same, inpatient and outpatient. It was that 1 year we had that aberration in there that probably caused some issues for Medicaid. So that shouldn't be an issue.
Right, that shouldn't. And if you are just projecting the use rates, inpatient, outpatient separate, you should still be able to do that.
So knowing that we have normally had one update factor, is there slide is looking at rate realignment in terms of inpatient and outpatient projections. I mean, historically, I haven't been involved in that particular process, but we can definitely. So I guess the question is to be able to answer, and so we might need to take it offline so we can ensure that we can answer it correctly. Is what you would get from the HSCRC to help you with your budget update, and how to interpret it and to make it most useful. So, for example, we've had lots of calls from payers to say, and I have an email from a payer saying, well, you know, you have this 1.65 and you're putting in a global budget that has a total of 3.68. Is the 3.68 on top of the 1.65? Meaning that are we going to give another rate increase of 3.68% on top of the 1.65? And the hospitals wish. But the 3.68 is very, very different than the 1.65. The 1.65 is a rate increase. So it says your unit rate was this amount last year, and we looked at that slide. We're going to increase your unit rate by 1.65%, but we don't know how many units you're going to have. That's up to you to estimate and figure out an insurance company or payer. The new model, the 3.68, includes both volume and price. So you will have to figure out how to untangle those to feed them into your model of price versus volume, and that will perplex. I know that's going to perplex the payers a little bit until we get the hang of it, and maybe we can figure a way out to work with you a little bit more closely on that.
But all the factors that we are going to get from the new models would be like a total factor, the total hospital factor.
The total global budget increase for the hospital. So we're going to start posting within the next couple of weeks all of the new global contracts on the internet, and we'll be making the information available about what the global budgets are for each hospital.
May I clarify that the different update factors? So traditionally, and as Steve explained in 2014, we have one single update factor for inpatient and outpatient. In fiscal year 2013, I believe, our waiver was showing us that we were failing the waiver back in June when we were discussing the July update. So the commission decided to have a differential update. So the inpatient rates were, I believe, declined by -1%, and outpatient rates were increased by 0.7% to give some revenue for the hospital. So overall, the average was 0.3%. So in that case, we split the update factor between inpatient and outpatient.
And it did create some problems for Medicaid when they were doing their estimates that year, and hence we had some issues with the Medicaid budget that year as well.
So, but it sounds like we could do some more work, and we could provide some more help and guidance to Medicaid and maybe others as they think about how to plug this into their update models.
Okay.
Moving along to the next topic here, and somehow I have
hit F5, I think you'll get there. You got to scroll all the way down.
Close your eyes.
Yeah, you're right.
Read your eyes.
Switch down. It's not going. Oh, there we go. It's not going quickly.
Let me take this back and drive it from here. I think we separated the driver and take it back and connect the dock and machine.
Just a quick question while we're technically
technology is catching up. Is it 3.58 or 3.66?
3.58. Plus the population adjustment, which is roughly 0.6, so it's roughly 4.2.
We're there. Where we want to be?
Yes. So are there other questions before we move forward? So what we need to do in terms of getting to July 1, because I think we need to make sure that we keep our eye on that goal, as Gary said, of July 1 as an implementation date, meaning that we have to complete recommendations, and the Commission has to adopt recommendations in June, an update approach. And we'll need an update approach and then the actual update recommendation for global budgets. And then we will also need updates for revenues that are not under a global budget. So there will be some revenues that are outside of a global budget. So for example, some hospitals are excluding their out-of-state from the global budgets, but we still regulate those, and we will need to have a process to update those. There may be some hospitals who don't have global budgets in place at that time. And then there are some other short-term adjustments and policies that we need to have in place that will affect the amount of revenue that is available to distribute under a global budget scenario, and we need to work our way through and talk through those. And then there are, beyond July, there are some important policies that we need to get to and to begin to discuss, and then ultimately to get to the strategic direction of payment models. But it'll be important for us not to delve too far into the beyond July work, because we could get off the road and not make it to a July 1 update process. Yes. So, so specifically in terms of the list of things, and feel free to interrupt or ask for clarification as we go through the list of things that we're thinking that we need to discuss and to work our way through in terms of recommendations before the for the update process. What will our approach be for non-global revenues? And you know, going back to the model that we've used in the past, will it be the inflation minus the productivity model of the past? And are there other policies that will need to be put in place for this revenue? And we may not finish that conversation before July 1 update, but at least should we have some sort of per case type of system still in place, or we don't need it right now. Right now, the concept is at this point that the per case system ceases to exist. But if we have significant revenues excluded, we'll need to continue to have some methods to make sure that they're reasonable. Then we have the update for global methods, and some of the things that we need to think about are we going to use an inflation concept to update the global methods, or is there some other concept to use? Is there a trend? And the our insurance colleagues tend to use trends in their models. They use an actuarial trend, and they look forward to say, well, this is how much we're going to trend outpatient, and this is how much we're going to trend inpatient, and they have different trend factors for different products and different lines of business. So, we may not get too far along on that particular discussion this year, but at least it's one to begin the process of raising. Do we do an inflation adjustment or a trend adjustment? How much? And the staff is very focused on having a sizable margin between the charge per case models and global models in terms of the update factor. So how much should that margin be? We'll want to review the demographic adjustments. The staff created a demographic adjustment for the global model discussions and conversions that we're doing, but now we want to bring that to the work group and have you review it and make recommendations regarding whether that approach is a good one or it needs some modifications. Steve started out in the beginning to talk about uncompensated care, and there are really three things that we've identified regarding uncompensated care to discuss. One is what is the impact of ACA, and in particular the Medicaid enrollment how is that going to affect uncompensated care? There was a growth in uncompensated care between 2012 and 2013, and our formula growth is recognized as a cost increase. So we would have to account for that growth if we were going to fund it in rate, and it's about 0.5%. So if we were saying, well, how much is available for other factors, it would be 3.58 minus 0.5%. To start with, if that were the only factor. And then the third thing is the formula. As we have been looking at the data, we are fairly convinced, although we now need to really test that with data, that the hospitals that have high undocumented immigrant populations may be disadvantaged, particularly as we go through the Medicaid expansion in the uncompensated care model, because they may be left with more uncompensated care than hospitals that have patients that are heavily covered under the Medicaid expansion. And so we want to test some models that include measures of potential measures to compensate for that, as well as generally look at the formula and how we would adjust the formula, which relies partially on a 3-year trend when we're changing the coverage under the ACA. We always have an update factor that includes changes in assessments, and we'll need to just look at what's going on with that and how it affects the figures available in the budget. There are some changes that are afloat in the legislature now to change the MHIP assessment, which is the MHIP stands for
Maryland Health Insurance. It's the Maryland Health Insurance Plan.
And the legislature is considering having that assessment from 1% to 0.5%, and out of the amount that's eliminated, allowing $40 million to be accessed through HSCRC grants, similar to the nursing grants that we have, based on applications, and that would be to support community partnerships and it could include a number of things, including it could include care coordination infrastructure, or it could include partnerships with that involve physicians or nursing homes or local health departments or a number of other things. But anyway, that'll be something that affects the budget. Then we also have the quality-based payments and how that fits into the global budget updates, or all of the budget updates, whether we're using scaling, meaning they're revenue neutral adjustments, or there are positive incentives available in the new model, and how that gets taken into account. We had a readmission shared savings adjustment of 0.2% during the past year, and we'll need to discuss what policies are going to be applied for readmissions during this update process. And I already mentioned the other possible positive incentives that could be related to these programs, value-based programs, or other incentive programs. One of the things that I don't have listed here, but I've added on, is really goes back to laying out the global contract policies and seeing if any of those need to be updated. Because there are actually quite a few policies that are embedded in the contracts related to charge limit mechanisms, et cetera. And David Gajewski has actually volunteered to lead the process of reviewing the contract policies and bringing that forward for us to look at. I think, Mike, you mentioned guardrails and making sure that we put that into the discussion process. Alice, can you move me on to the next page here, please? The other things that we have to discuss is the Germantown Hospital opening and how that's going to affect revenue availability, how that will affect how much of the Germantown Hospital will come through slippage, and we've been working on that, and we'll present a policy paper on that, and the market share adjustments that would result from that, because even if we don't have a permanent policy on market share adjustments, we will certainly be addressing that in the context of Germantown Hospital opening. There may be some other short-term mechanisms that we want to discuss and bring forward. One of those that has arisen during our global budget reviews relates to transfers to the academic medical centers, and beyond what's provided for in a population adjustment, with the incentives of a global model of making sure that if transfers increase to academic medical centers, that we take account of that in how we maintain the global budgets for transferring organizations. So we do have some history on that issue, and there may be some increasing transfers that happen after global budgets are in place. They may actually be technology-driven, and we don't want to suggest that you shouldn't have more transfers. It might be a very good economic decision, but it's the one that the commission staff wants to address, and then also making sure that we have a plan in place for cases that are excluded and how they will affect the global budgets going forward. Before we and so those are the things that we would say are on that immediate agenda that have to be done to get the update in place. Are there other things that people are thinking about or questions about those before we go on to some of the longer term or things beyond the immediate adjustment? And you will see that we didn't put a general market share adjustment in that topic list. I think that could slow us down if we put that in right this second, that we might not get to the get through the update process because it could weigh us down too long. So I think we need to get the update done first, and then we can get on to a more thorough discussion of the market share adjustment.
You know, Donna, I think this issue about what moves out unregulated, I think we need it here maybe as a placeholder. We may, we may pass if there's nothing, not enough, data, not enough views in it yet, but I think we need to at least get it here in so we're not forgetting about it.
So it's, we'll put it on here, and it's in the contract, so it's one of the things that we should review. There is a provision in the contract, and I think there might even be, based on some of the early things that we're seeing round and about down in Annapolis, there might end up being some language even about it down in Annapolis. So I think everybody will be focused on making sure that we're not shifting without reducing the global budget. We have to keep our eyes on it, and it's a topic of the data and infrastructure work group, and we'll all need to keep our eyes on it because we don't want to double pay.
Could you explain what excluded cases are?
Yes. So one of the things that we're focused on is in the charge per case system, there were certain quaternary cases that were excluded from global budget or from charge per case budgets because they had highly variable cost per case. And so we're really working our way through thinking of that and examining the data in the context of dealing with the global budget to see if we want to exclude those cases, and if we exclude them, do we just carve them out into their own global budget, or do we actually exclude them? And if we exclude them, how will we maintain a budgeted revenue for them? So, for example, I'll give you an example. We interviewed Kaiser Permanente to see how they did it, because they have a lot of hospitals that they own and contract with. And for some of the quaternary care, they create an annual budget, but they rebase it every year. And so it's prospective and it's fixed, but it's rebased. So there are some options that were
reinsurance.
Well, it's not. We're talking about the hospital side, so it's not really a stop loss. It might even it's a prospective budget, but if they get to the end of the year and they see that the hospital was shortchanged too much in the prior year, they might make up for it a little bit in the next budget. But at least it gives a fixed amount for a period of time so that you can lock down your revenue budget. So that's an example of something that we might be looking at for excluded cases. Or there could be an option to leave them on a fee-for-service system that leaves us a little bit more open-ended in terms of knowing whether we've got the revenue locked down and how much variability there could be, and keeping on top of monitoring it and the trend. So, for example, the kidney transplants might increase because they have new procedures. The good news is if the length of stay goes down to 1 day or 2 days, the cost might go down a lot at the same time as the new procedure can actually use more live donor for kidneys. So there are factors to consider of including or excluding those cases from a global budget. Yes.
Donna, you mentioned that our relationship with CMS involves the Maryland Medicare population. If we're treating Medicare patients from out of state who, for whatever reason, elect to receive their care at Maryland hospitals, either outpatient or inpatient, how does that fall into the system as far as CMS is concerned?
Well, we're still regulating the rates for all patients, regardless of in-state or out-of-state. Most of the global budgets include those patients in the global budget. Not all of them, but most of them. As far as things like readmission and quality, they're under the same readmission and quality programs that we have for the state. They are not part of the savings targets that CMS has because they're calculated on a population-based revenue. So there's no way for us to really put those out-of-state residents on a population basis, and therefore they're excluded. And there are some limits where if they grew, if all of a sudden we've been mightily steady in terms of our percent of revenue from out of state for many years, and CMS has some language in our contract that says if they grow by 15% from what they were in the past as a percentage of revenue, then we want to know why. But basically they're wanting us to make sure that we keep all of the good quality programs and the readmission programs and the revenue controls on those out-of-state patients. Other topics, are there things on that short-term list that you think that we have missed? And we'll quickly run through the longer-term list, the beyond immediate list. Certainly at the top of the list, but not necessarily first under consideration, is the direction of model development, and beyond global budgets, or as tweaking global budgets. How should we take the model going forward? Then the topic that's sure to bring lots of opinions out is how should we adjust for market share if hospitals, and this gets also to the unregulated. It's not just because it is a market share shift if it's going out of the hospital, but how do we make these adjustments? We've made them already for unregulated, so we have methodologies to use in the interim. But how should we make these adjustments both between hospitals and between regulated and unregulated entities in hospitals? When and how should we bring efficiency into the equation? Are there other model adjustments that we want to consider? And this goes to Mike's point that he raised. What should we, if we see an overage, if we're running over where we need to be, are there midterm corrections, and how should we make those corrections? And Mike, do you agree that that's something that we can put after the update, or do we need to have it done before the update? The timeline is good. Capital policies, and this is not something way down the road. It's near and dear. How are we going to address capital? There will be longer-term issues, but we have short-term issues relating to capital expenditures and capital costs that we have to address. As we move down the road, what kind of thinking should we have about excess capacity and policies, including things like in our annual filing, should we segregate costs for excess capacity, so they don't get allocated into particular revenue centers, but they're shown more, for example, as a stranded cost. Then maybe as we move further into discussions of update factors, we may not be able to get too sophisticated in terms of the types of updates that we do this year, but we might talk about whether we want to get more or different updates in play for the following year. So we'll see where that takes us. But for example, do we want to consider a different trend factor for Medicare and non-Medicare, inpatient and outpatient, service A versus service B? And you can see that that could easily fall into keeping us from getting an update out the door for this year, but it is one that deserves some more discussion, I think. Those are the beyond immediate that we have put on our list.
Is it possible to include amongst those one other category, the guardrails, as Steve mentioned, just what we can do to make sure that cost savings don't come at the expense of patients, either by discouraging people with a lot of problems from coming to the hospital or undercare, make sure that the savings comes in the good ways that we've talked about and not in ways that hurt patients, and whatever that means, incentives, penalties, whatever it means, but that's up there as one of our key items.
I think we can put it up there, and it probably is something that belongs back in the performance measures work group, which is where we might really focus on how we would measure it and make sure that it doesn't happen, and et cetera and so forth. So I think, but we can keep it in both places. Good. And ask for a report from the performance measures work group.
That'd be great. Thank you.
Donna, this is Ray Gray. I think we also ought to look outside the hospital industry at the incentives that are provided to other providers, be they physicians or nursing homes. If you have the hospitals under a global budget, global management, and you have other providers that work within the hospitals and receive patients post-acute to the hospital, or if you're trying to stop the PQI, the preventive quality indicators, then you have to look at the primary care physicians as well. We need to look beyond the hospital for aligning incentives for quality and improvement, as well as patient satisfaction, et cetera. And you know, in the fourth year, is it the fourth year of this big, hairy agreement, we're supposed to make a proposal for an all-inclusive payment model, which goes beyond hospitals. So therefore, we should start thinking today about how we look at all of those costs that we expect to put into that proposal that we present to CMS.
And I wouldn't necessarily call it a payment model. So a total cost of care model where we would be responsible for the total cost of care. So I don't want the physicians to think that we're designing on how to set their fee schedule.
That, so you don't have to worry about it.
We're not thinking about it. You can imagine that if fee-for-service is not the gold standard, that having the rate commission run after regulating physician fee schedules is not the gold standard either. So you can forget about it.
Thank you.
But it's really focused on yes, and so I think what you pointed out earlier and what you're pointing out here is, before we start talking about the model, let's make sure we get the physician alignment group in the same room with us to talk about it.
It's beyond physicians. It's also the subacute, post-acute providers.
It's alternative, yeah. It's
exactly.
Physicians and alternatives, right?
It's all the things the commission doesn't regulate.
Right. I think Ray, what might be helpful here is when we're talking short-term versus long-term. There's clearly short-term the things we need to focus on between now and getting an update in place for July 1st. Then long-term, some of the things that you've identified on this slide, I think are probably, say, within the calendar 14, early 2015 timeframe. But I think, Ray, clearly what you're talking about is, and not that I think we want to be here for 2 or 3 years as a work group, but those are the kinds of things that we need to be thinking through. What's the role of this work group after, say, the initial report is done in July, to provide feedback for the development of Phase 2 of this waiver for what would go into the application 3 years from now. So I'm just thinking in terms of time frame, there's short-term and then there's sort of 2 types of long-term in terms of the things that still focus on Phase 1 of the application, the hospital rate setting system, and then beyond that, we clearly do need to bring in the other provider types into this discussion as well. And part of it is through the physician alignment work group, but there may be other options as well.
So Mike, I think what you're pointing out is the beyond immediate is that we should probably put a timeline of when we would really want to have something with you all, put a timeline of when we would want to address these different issues.
Yes. And if I could, I did want to make one comment on the beyond immediate. I have some concern about the capital policy and how far we push that off. I think there are clearly a lot of innovations that are going on now that we need to make sure are recognized even in the July 1st update, that we are providing for adequate funding for that kind of innovation. I put it in the broader category of infrastructure investment, but specifically for those types of capital innovations that will allow us to be more successful in reducing readmissions, reducing complications, those things to be successful in meeting those targets. I want to make sure that we have some discussion about whether we provide for some of that funding in the July 1 update as opposed to any longer-term policy.
Donna, if we're going to move stuff a little further up the to-do list, I have another thought consideration. It's in this efficiency measure,
yes.
And you and I've spoken before about this, and it's just something for the group to consider. I'm going to assume that hospitals will aggressively participate in this new arena here, and that will be successful. But one measure of success will be moving care to lower cost settings that are not hospital-based. So take, for example, our health system has 2 hospitals in West Baltimore, and there's a very high use rate coming out of West Baltimore. Well, in order for us to be successful in moving care out of the expensive hospitals, we're going to have to invest a lot of money into community services that have no payment source, except the savings that comes from the hospital care being shifted out. What will result will be higher hospital rates. So we got to make sure when we're thinking about hospital efficiency that we broaden that view and not have a very traditional view of what a hospital cost should be. So I think this is going to be a key point and whether or not we can sustain the success that I think we'll achieve out of this. And so I've been concerned about that for a while because it does mean pick up a big budget, go out to the community where no one's paying these bills, and try to get a lower cost setting, go to the community. But that cost is going to be borne by the folks paying for the hospital bills. And that may tire people after a while. So something I'd like to see us talk about sooner than later. Because as people gear up, this mechanism is infrastructure. It's going to be longer-term investments. And if all of a sudden the measurement of what efficiency looks like changes, then that could really mess up the incentive to get out there and do this. And what you're describing is actually good for everyone. Right?
Absolutely.
And so I agree we should make this, move it up. Yeah. And I'm not sure moving it up means everything will get moved up.
I think about this in the context of, we're building a mechanism now that's going to apply for the next few years, and then we're going to broaden that mechanism after that. And so we need to be conscious, I think, generally, in all the last couple of points fit into the context of being conscious generally that of the fact that the system we're building for the next couple of years has to be able to fit into the broader system we're going to be building beyond that. And so I think all of these topics kind of get brought in under that, because we can't go to a population-based system if we're just going to focus on the hospital. We have to, and I took it that's why we have a physician alignment, and I kind of always read in physician and other alignment.
I have a question, comment. As I see this whole process, it's exactly what you described. Obviously this current reimbursement model is not working to the advantage of patients because people are not getting paid to do the things that they ought to be doing. So we're changing the reimbursement model. But me as a purchaser, I'm stuck in the old model. And I am going to be paying my insurance carriers on. That's what I'd like on this agenda. How am I going to be paying off my insurance carriers? Because am I going to be paying University of Maryland Hospital System for those few patients that are left in the system? And therefore my rates will go through the roof. This is from a big picture perspective, it makes a whole lot of sense, but I want to see that the benefit flows back to me.
I have another comment just to add to the mix, since we're sort of throwing things out like that. And it kind of comes to your point, Hank, about if we're going to start doing things in different settings. Is there going to be some ability for us to have discussions here about benefit design? For example, if we take something out of the inpatient setting and move it to an outpatient setting, and the individual now has a much higher cost to bear because it's covered differently, we are not going to be able to move the dot to low cost, or we're going to have a lot of unhappy people that are complaining to the hospitals because they didn't realize they were going to have to pick up this higher amount of, under their high deductible plans or whatever it might be. So I just throw that out as a discussion point. I think there might be some innovative thoughts we may have about using our facilities. So we already have, I hadn't heard that stranded cost concept before, so that was interesting today. But it may mean, it might be some flexibility to say if you want to do a follow-up visit, say, at your urgent care center for a patient, that has a different benefit structure to it, so that it's efficient and effective to use some cost of a capital, facility already. But right now, it's not matching up necessarily to what the individual would have to pay because of the way it's designed by location. So it's just a thought to throw out there as we move on to the idea of everything sort of changing.
So that's actually to say, should we look at how we define regulated space under the HSCRC requirements? Is that the question partly?
I don't know if it can actually fall under this group, but I bring it up because I think it's a consideration as we look at the broader picture of the doing, under that category, still trying to do the right thing, that all of us, whether we're, in our own plan or whether somebody's buying insurance, the benefit structure of these plans are old school compared to where we're trying to head.
You're on the insurance side.
Yes. Mm-hmm. And so what I'm saying is there's going to be, we may make some regulatory components to it, but then this whole consumerism that's out there on the rise and the high deductible health plans that's on the rise is going to direct people, they'll have the incentive to dollars that are out of pocket to go to a particular place.
Michelle, it's only one of the disconnects between the insurance system and the reimbursement system. There's a few of them that need to be connected.
Yeah. So I just think that somehow.
I think, Michelle, this may come up. If we want to just find a place to touch it here,
right.
I think it'll come up when we talk about uncompensated care.
Right.
That's
What's
exactly
going to
right.
happen to it in the future?
That's right, Hank, because our uncompensated care may be changing. It may not be people without insurance, but people that can't afford to pay the $5,000 high deductible.
That's true, Hank, but in addition, if you're trying to push patients into alternative care settings, and it's 40% out of pocket to go to that alternative care setting, and it's 20% to come into the hospital, they're not going to go. Look at the pushback on observation.
Oh, no, I'm just saying this is where we'll touch it. I don't think you're right. Both of you guys are right. No question. At least we'll have a place to touch it. We'll start the conversation.
Quite frankly, I'm not sure, sitting over here, the benefit plans now, that we're driving people to those alternatives and then sending them. So I'm not sure I would agree we have a misalignment at this point on that.
Well, we get pushback, Gary. Yeah, we get pushback.
Donna, I think, though, to your point, that we do need to revisit the definition of regulated versus unregulated space. I think that there is probably going to be some movement between the two settings based on the incentives that are in place. And as we free up capacity in our current structures, we might be challenged to figure out how we can provide unregulated services in that space, given the current definitions.
So there's the issue of the space usage, and I'll tell you one of the other ones that has been coming up some is if people want to provide disease management care like diabetes care, and they want to provide it right next to the place where the people are coming in for the care, but they really don't want to necessarily regulate that revenue because it causes the prices to be inflated and it takes up revenue capacity. So so some of those conversations around unregulated space could get added to the agenda.
And maybe we want to pay for Google Chrome. We can monitor their diabetes levels through their contact lenses.
I thought Mike said we don't want to be here for 2 to 3 years. At least 3 years.
Yeah, Shirley's telling me it's time to adjourn, but I do want to make sure that we capture anything else that folks want to put on it.
Yeah, just one other thing. So we're throwing out the concept of good volume versus bad volume, and I don't know that there's a good way, and maybe this is one of the exercises of the data group, to look at use rates. Or, my hospital may be, we have a lot of medical services, so we may have a lot of bad volume, but that's because we're attracting that volume, versus another hospital that, has a different array of services. So how do you really evaluate, is a hospital effective at driving down, the right kinds of volume? So it strikes me that somehow gets a use rate discussion, and we also hear comparisons of Maryland versus the rest of the nation, but it's, unless we do a big data study, and maybe somebody has, it would just be good to have the data to validate it, and I think once we see the data, we might see some interesting things in terms of how to use it in terms of rate setting.
So that the potentially avoidable volumes are being looked at by the performance measure work group?
Yes. We've been concentrating on how to define the bad volume, so to speak, and we are concentrating on the unplanned care, readmissions, and preventable, avoidable admissions, and some ambulatory care. But the issue of how you would measure the hospital performance on it is a complex one, as you pointed out, and I think it will take some time for us to get our heads around distribution models and defining populations and accountability for a hospital.
And it's beyond immediate, but it strikes me as something we ought to start working on.
The efficiency issue.
Yeah, I can tell you outside of Maryland, for us, as we engage with a hospital, Kevin, we're probably looking at 50, 60 different measures with a hospital and seeing where they fall. And obviously, when we go back to the hospital, we're picking the ones that, and providing incentives, the ones that they need improvement on. But those are different per hospital. And one of the things that I would like to see at some point is there would be some ability to have some variations in the incentives by hospitals, because hospitals perform differently against the other. So that's I think I'm echoing what you're trying to say.
Or you could have two hospitals in one market. One is a surgery OB hospital,
right.
The other is a medical hospital, and one, depending on the policies that are developed, could really
be different.
Yeah.
Yep.
And that comes into the market share considerations too, because if you're talking about market shares of hospitals, you have to consider for what services.
Any other comments? Any comments from the audience?
We also have
Are there
20,
any on the
yeah.
phone that have questions or comments?
We have 20. We used to have 25, now 21, and then there were some questions that I answered, but they were kind of technical questions. If there is any other question that I didn't either answer, or you would like to just ask by phone, this is the time.
We're good.
Is that David Mann?
No, it's Mike Curran saying we're good.
Oh, okay. If you want to ask, you can raise your hand and we'll unmute you, if anybody else.
Well, I want to thank you for joining us today and kicking us off on this